Rabna Simpson. So I'm the division chief for hematology oncology, and I have the pleasure of introducing our speakers this morning. But I wanted to start with a land acknowledgement. So mine's a little bit personal. So I want to share a bit about myself first, saying that I'm a Ghanaian immigrant who moved to this nation with my family as a very young child. And like many immigrants and settlers, I've benefited greatly from living in this country. And so in recognizing the privilege that I have by residing on Turtle Island, I would like to acknowledge that the land upon which we learn, work, and gather is the traditional and unceded territory of the Anishinaabe Algonquin people, and to call out the historical oppression and inequities that continue to perpetuate harm to Indigenous peoples in this nation. With this acknowledgement, I commit to pursuing a better understanding of the histories, cultures, and contributions of Indigenous people, and to dismantling the oppressive, systemic, and institutional structures that have eroded their health, education, and social outcomes. And so with that, I'm happy to introduce our invited speakers, Drs. Pierre Teira and Henrique Bittencourt. So Dr. Pierre Teira obtained his medical degree in pediatrics and then his specialty certification in pediatric hematology oncology in Toulouse and then in Paris, France. His special interest was in allogeneic hematopoietic stem cell transplantation for children. He moved to CHU Sainte Justine Hospital in 2009, and since his arrival, he has been in charge of programs for neuroblastoma, autologous stem cell transplant for malignant diseases, and allogeneic hematopoietic stem cell transplant for non-malignant diseases. Dr. Teira has also served as Chief of Hematology Oncology at Sainte Justine. Dr. Henrique Bittencourt obtained his medical degree in internal medicine, followed by his specialty training in hematology oncology in Brazil at Porto Alegre. He completed a fellowship in allogeneic hematopoietic stem cell transplant in Paris, France, before returning to Brazil as a hematologist and bone marrow transplant specialist. He moved to CHU Sainte Justine in 2010. Since his arrival, he's overseen programs of allogeneic hematopoietic stem cell transplant for hematologic malignancies and CAR-T for acute lymphoblastic lymphoma. So on the heels of September, which was both Sickle Cell Disease Awareness Month and Childhood Cancer Awareness Month, we're very happy to have Drs. Bittencourt and Teira to come and present. They're important allies and partners in the care of the children in our division and across the hospital, and work very closely with our post-BMT transplant program, which is led by Dr. Leslie Abbott and supported by Dr. Brianna Empringham, as well as Amy Givogner's practitioner, and Julie Lemieux, who is the nurse case manager. So I'm very happy to welcome them to the podium as they present on contemporary outcomes for cellular therapies for pediatric diseases, and they describe their experience related to cellular therapies over the past decade. So thank you so much for being here.
Thank you, Rabina. Okay, so I'm Dr. Teira, and you will meet my colleague, Dr. Bittencourt, in a few minutes for the second part of the talk. So I'm very happy to be here at CHEO today to present you our results of cellular therapy for pediatric disease, our experience over the last 8 years. How can we move from one slide to another? A little technical issue. Okay, so what's zero? Now it's so I have no conflict of interest to disclose, but I would like to emphasize the many collaboration with many organizations and people we have to help us in better treating children in stem cell therapy. So we have the Philanthropic Foundation in Quebec, who is very important to find a donor in international donor registry, scientific organization, and also the different pediatric hemato-oncology hospital in Quebec and you guys at CHEO. So the learning objective today are to present the basic results in terms of activity, overall survival, transplanted-related mortality, relapse, death from relapse for our patients treated with cellular therapy. The methodology is very simple. It's a compilation of each annual report we do for our insurance quality accreditation organization, the FACT organization, every year. So we took the data from our cellular therapy database. and we compile all the data for the last 8 years. At Sainte Justine, we perform different sort of cellular therapy, allogeneic and autologous stem cell transplantation, chimeric antigen receptor T lymphocyte for the acute lymphoblastic leukemia, donor lymphocyte infusions, and cytotoxic T cell against viruses. So for those in the room who are not very familiar with stem cell therapy, allogeneic stem cell transplantation is a transplantation with a donor, with not the patient. And we use this treatment for malignant or non-malignant disease. So the first step is to find a donor. It can be a matched donor, a sibling, or a donor matched from international registry, or also now mismatched donors are also available, such as a cord blood from blood bank, or a half-matched donor, a haplo donor, who can be the father, the mother, or a half-matched sibling. So the first step for transplantation is to destroy the bone marrow of the patient. For that purpose, we use total body radiation for a patient with acute lymphoblastic leukemia, or high dose of chemotherapy for all other indications of transplantation. We also have to destroy the immune system from the patient to prevent rejection of the bone marrow. And for that, we infuse antibodies against T lymphocyte. After that, we infuse the stem cell. It's a very simple and basic transfusion, like a red blood cell transfusion. And we wait for the new bone marrow engraft and produce blood cells. So during this time, the patient has to be in hospital for 3 to 6 weeks. It is the time of aplasia, so the patient needs a mini transfusion. It often experiences mucositis, which is a painful complication related to chemotherapy with lesions in the throat, the mouth, or the gut. Often the patient needs enteral feeding support. No. He can also present with severe infection, notably bacterial infection, or organ toxicity such as veno-occlusive disease in the liver or thrombotic microangiopathy in the kidney. And the patient is also at risk of graft rejection. And this second part of transplantation is the time at higher risk of transplanted-related mortality. After that, there is 3 months of immunologic recovery, mainly at home, with frequent visit at hospital. And during this time, the patient is at risk of immunologic reaction from the donor cells against the patient cells, which is named graft versus host disease. And to prevent this complication, even if the patient is deeply immunocompromised, we have to give immunosuppressive drugs for a couple of months. This immunologic effect may be also beneficial to prevent relapse of leukemia because the immunologic cells from the donor do not differentiate normal cells and leukemic cells from the patient. It can attack both of them. There is still risk of infection, mainly by viruses, CMV, adenovirus, or EBV at this time. The risk of relapse from hematologic malignancies or solid tumor is present during the first 2 years after transplantation. And there is also residual risk of secondary graft rejection for non-malignant disease. So finally, after 6 to 12 months, the patient is able to go back to his normal life, and which is very important, he can discontinue all medications. This is very different from solid organ transplant, where a patient has to take immunosuppressive drug for all his life. After stem cell transplantation, there is an immunologic tolerance story that takes place and allows to discontinue all medication. And the patient has to be revaccinated again with a complete schedule of vaccination. Autologous stem cell transplantation is a much more simple stem cell transplantation. It's used for a treatment of solid tumor, mainly like neuroblastoma, lymphoma, or CNS tumor. The donor is the patient, so we have to collect the stem cell from the patient a few weeks before going to autologous stem cell transplantation. We use GCSF to stimulate the production of stem cell from the bone marrow. Then we collect the stem cell by apheresis, and we keep the stem cell frozen until use. For conditioning, we use high dose of chemotherapy. There is no indication for a total body irradiation for this kind of solid tumor. The infusion of the stem cell is done after throwing the cell in the patient room. And the time of aplasia is usually shorter with autologous stem cell. Usually neutrophils recover at day 10 or 11 after infusion of the bone marrow. The patient can present with the same complication like mucositis, veno-occlusive disease, thrombotic microangiopathy. This is a time at risk of transplantation-related mortality. And finally, the third part is also shorter compared to allogeneic stem cell transplantation. The risk of infection is lower after autologous stem cell transplantation because the patient is less immunocompromised than after allogeneic stem cell transplantation. And very importantly, there is no risk of graft rejection and no risk of graft versus host disease. So usually the patient is back to his normal life between 3 and 6 months after transplantation. CAR T cell, Dr. Bittencourt will explain a little bit more in a few minutes. There are T lymphocytes from the patients that are genetically modified to harbor a new receptor at their surface that enable the T cell to recognize specific antigen on the cancer cell surface. So at Sainte Justine, it's used for treatment of refractory or relapsed B leukemia, lymphoblastic leukemia, but in adult hospital, they also have CAR T cell for lymphoma, and worldwide, many different CAR T cell are in development for acute myeloid leukemia, CNS tumor, and neuroblastoma. DLI, it's for donor lymphocyte infusions, are T lymphocytes from the donor, the same donors that donate the bone marrow. The T lymphocytes are collected by apheresis, usually after allogeneic stem cell transplantation, and it's used for relapse of leukemia or secondary progressive graft rejection. And the risk of DLI is to trigger graft versus host disease. Finally, TTL are T lymphocytes from the donor of the bone marrow or from a third-party donor. It can be a different donor. Oops, sorry. They are collected by apheresis again, and then they are selected and activated in the cell therapy laboratory against viral peptide. And they can be used after allogeneic stem cell transplantation or solid organ transplantation to treat refractory CMV or EBV or adenovirus infection. They were available on research protocol at Sainte Justine until this year, but now the protocol is closed. And in the future, we hope to develop our own CTL at Sainte Justine against this virus. So activity now. Over the last 8 years, we saw a continuous increase in our activity from 38 cellular therapy to 89 last year. That represents close to 500 different cellular therapy over 8 years. This increase of activity is explained mainly by the increased number of patients referred to our center from 36 to 64 last year. It's also explained by new treatments like CAR T cell, DLI, and CTL, and also by patients who receive sequentially different cellular therapy, such as a patient with CNS tumor who can have a triple autologous stem cell transplantation, or patients with leukemia who are treated at relapse with CAR T cell, and if the patient relapses again after CAR T cell, they can receive allogeneic stem cell. So this increase in cellular therapy is driven mainly by malignant disease. And the activity for non-malignant disease remains stable over the last 8 years. That means patients with non-malignant disease have to wait a little bit more to have a room in the department for their cellular. Regarding malignant disease, we performed 278 cellular therapy for malignant disease over the last 8 years. The main diagnosis was acute lymphoblastic leukemia. And patients were treated, half of them by allogeneic transplantation and the other half by CAR T cell. The second diagnosis is acute myeloid leukemia, mainly treated with allogeneic stem cell transplantation. There is also a very specific type of acute myeloid leukemia, the M3 leukemias that can be treated by autologous stem cell. For solid tumors, the main diagnoses are neuroblastoma and CNS tumor. Neuroblastoma can be treated by allogeneic stem cell transplantation at relapse, or usually by autologous stem cell transplantation in first line. And CNS tumor are treated only with autologous stem cell transplantation. For lymphoma, depending on the specific type of lymphoma, the best choice may be allogeneic stem cell or autologous stem cell transplantation. And we also have very rare hematologic malignancies that are treated mainly by allogeneic, and rare other sort of solid tumors, such as the wing sarcoma or carcinomas, that can be rarely indicated for autologous stem cell transplantation. So globally, can I move this bar?
Looking it up on Google.
Ah, okay. Okay, thank you very much. So for my lung disease, so for my lung disease, we perform 45% of allogeneic stem cell transplantation. 40% of patients were treated with autologous stem cell transplantation, and the rest by CAP. Non-malignant disease now. We performed 141 cellular therapy for non-malignant disease. The main diagnosis was immunodeficiency, followed by aplastic anemia, hemoglobinopathies, inherited bone marrow failure syndrome, such as Fanconi anemia, for instance, and more rarely metabolic disease or other very rare indications. So, except for one patient, who was treated with autologous stem cell transplantation for refractory multiple sclerosis with a protocol developed by your adult colleague here in Ottawa in hemato-oncology, and the treatment was very successful. Otherwise, all the patients with non-malignant disease are treated by allogeneic stem cell. And non-malignant disease are a very large group of very rare and very different diseases. So it's a little bit tricky to treat, more tricky than malignant disease. So for instance, immunodeficiency, now we have more than 400 monogenic different diseases. Only for SCID, we have 20 different diseases. For combined immunodeficiency, 40 diseases. Inherited bone marrow failure syndrome are also a large group of different diseases with different issues and possible organ toxicities. Metabolic disease are mainly represented by earlier disease, so mucopolysaccharidosis, and with by a very, very rare disease like osteopetrosis or adrenoleukodystrophy. And finally, the rare other diagnoses were treated with transplantation were inflammatory disease or polychondritis. Regarding the type of cellular therapy performed, it was mainly allogeneic stem cell transplantation. For half of the indication were for malignant disease and the other half for non-malignant disease. A quarter of patients receive autologous stem cell transplantation and 10% CAR T cell or DLI. And globally, 2/3 of our patients have malignant disease and 1/3 non-malignant disease. And we also perform second allogeneic stem cell transplantation for malignant disease in case of relapse or rejection, and for non-malignant disease, mainly for rejection, secondary rejection. So the patient from CHEO now. Over the last 8 years, we performed 68 cellular therapy for 43 patients. It was half malignant disease and the other half non-malignant disease. So compared to the rest of patients treated at Sainte Justine, there is a trend to more non-malignant disease from CHEO, notably SCID, with a large cohort of SCID ADA patients from Northern Ontario, and also hemoglobinopathies. And the other trend, different from the rest of our patients, is less solid tumor from CHU. But globally, this is the same kind of diagnosis. Regarding the indication of stem cell transplantation, there are 3 different categories of disease. The first one is disease at risk of death in short term. And for this kind of disease, usually stem cell transplantation is the better and often only treatment available to prevent death and to offer a cure. So, for instance, it's acute lymphoblastic leukemia, severe aplastic anemia. So, in this situation, the indication of transplantation is very simple to do, because this is the best option and often the only option. A second group is patients with disease which put them at risk of death, not at short term, but rather at long term in adulthood, not in childhood. But this disease have many complications in childhood and adulthood, and the patient often have poor quality of life. This is typically the situation of patients with severe sickle cell disease. So the point in this second group is that with stem cell transplantation, we have risk of death at short term that is not present with the disease itself. So we have to keep the risk of death related to transplantation as low as possible for this patient. But in long term, the benefit of stem cell transplantation are far more superior to not doing transplantation. So in this situation, stem cell transplantation is usually the best option, but it's not the only option. There are other options, and notably option to not do a transplantation. And finally, the third group of patients is patients with complex disease where the medical problems are not limited to the hematopoietic cells, such as dyskeratosis or Fanconi anemia, or disease where the patient has been diagnosed with a mutation, but the patient is currently asymptomatic. There is a risk of, for instance, lymphoma in the future or severe immunologic complication when the patient becomes an adult, but currently the patient is doing very well. So in this situation, the transplantation is an option, but often we do not know for sure if it's the best option, or we do not have enough data regarding long-term possible side effects. So stem cell transplantation is an option, but we're not sure it's the best option, and that takes a lot of discussion with the family, with other specialists to define the best option for this patient. We also have 2 specific situations regarding indication. CAR T-cell for BLL. This is not our most effective treatment because the rate of cure with CAR T-cell is about 30 to 40%. It's lower than with allogeneic stem cell, about 60 to 70%. But the toxicity of CAR T-cell is very, very much lower than with allogeneic stem cell transplantation, because for allogeneic stem cell, we have to use total body radiation, and the patient can have a long list of long-term side effects with in relation to TBI. So CAR T-cell is always at Sainte Justine our first choice for relapse or refractory acute lymphoblastic leukemia. The other specific indication is triple autologous stem cell transplantation for young patients, less than 5 years with CNS tumor. Autologous stem cell transplantation is not more effective than radiotherapy, but radiotherapy of the whole brain and the spine have a huge burden of side effects, especially for neurodevelopment in these young children. So we prefer to use autologous stem cell transplantation. So in terms of survival, now over the last 8 years, we have a median follow-up of 4 years. And this is very good because the majority of deaths occur within 2 years after transplantation. So we have enough follow-up to have a solid result. So the probability to be alive is dependent on each disease, from 100% for very rare hematologic disease. We were very lucky with these patients to 72% for acute myeloid leukemia. So globally, the probability to be alive at 4 years after transplantation for malignant disease is about 74%, but it depends on every disease. For non-malignant disease, the probability is higher, far more higher, about 96% of overall survival with each different category of non-malignant disease. So globally, it's a probability of 95%. Transplanted-related mortality now, it's a big issue for us because it's death directly related to the treatment we prescribe. So we saw 15 deaths from transplanted-related mortality among 378 cellular therapies. So that represents 4% of them. The risk of TRM is the same for malignant and non-malignant disease, and this is the same also for allogenic and autologous stem cell transplantation. Autologous stem cell transplantation is not safer than allogenic stem cell transplantation regarding the risk of TRM. The cause of TRM for malignant disease, it's mainly a mix of infection and graft-versus-host disease. So we had a very, very rare case of acute cerebral GVHD disease in a patient with TLL. And otherwise, it's mainly bronchiolitis obliterans. Bronchiolitis obliterans is a chronic form of GVHD disease in the lung. And it's usually associated with infectious complication. So this is the main cause of TRM in allogeneic stem cell transplantation for malignant disease. The cause of TRM for autologous transplantation in malignant disease, it's usually organ toxicity with related to high dose of chemotherapy and with some peracute inflammation, usually in the lung with acute respiratory distress syndrome. We have 2 cases, or a very, very rare case of hyperacute pulmonary fibrosis within 1 year after transplantation for neuroblastoma. And also, unfortunately, we also had an accident, an accidental infusion of potassium and phosphorus in the patient with neuroblastoma. For non-malignant disease, the main cause of TRM is also infection. We had 1 case of refractory CMV for a patient from CHEO with sickle cell disease. Otherwise, we had mucormycosis in the patient with aplastic anemia, or EBV infection with a very unusual delayed veno-occlusive disease in a patient with a very rare and unknown disease called ribosomopathy without other than fundamental anemia. Oops. And a very rare case also of disseminated microangiopathy in a patient with ligase 4 deficiency. So in non-malignant disease, TRM is dominated by infection, but we also have unexpected toxicity in a patient with very rare disease we do not know very well. So in summary, for TRM, the main cause of TRM is infections, is related for 2 of them are in association with graft-versus-host disease. We hope that infectious complication and death related to infection may be something we could improve in the future with better prevention and maybe better treatments such as CTL for virus. The second cause is GVHD disease, dominated by bronchiolitis obliterans. And maybe this is something we could also improve in the future. We have new treatment and more effective treatment for GVHD disease. New treatment will come in the future also. And finally, the last cause can be named idiosyncratic toxicity. That means organ toxicity related to chemotherapy that we cannot anticipate by blood test or radiologic test in a patient. So this is something that will likely remain the same because it's very difficult to anticipate. Regarding relapse for malignant disease, you have to keep in mind that relapse is the main complication. We have some TRM, about 4%, but the main cause of death is relapse. So the risk of relapse is dependent on each diagnosis. Very high for autologous cell transplantation for patients with carcinoma or Ewing sarcoma. It doesn't work, so please do not refer us patients for autologous transplantation with Ewing sarcoma in relapse. It doesn't work. Or it even with acute myeloid leukemia, where stem cell transplantation usually works well, there is a high risk of relapse, about 45%. So that do not mean necessarily the patient will die, but we can do other intervention and second transplantation. So for some patients, but patients in relapse after allogeneic transplantation or autologous transplantation are at high risk of relapse. In summary, for malignant disease, the main cause of death is relapse. 80% of patients died from their relapse, and 20% from TRM. And for malignant disease, it's only TRM. Regarding patients from CHEO, so if we exclude CAR T cells that will be presented by Dr. Bittencourt, we perform 52 cellular therapy for your patients. So many were malignant disease, the other half malignant disease, half non-malignant disease. So globally, the results are pretty the same than for the rest of our patients, about 84% of overall survival and 2% of TRM. So this is very similar to the rest of our patients. So in conclusion, over the last 8 years, we had a continuous increase in cellular therapy activity. It seems that this year we have reached a plateau. We'll have about 70 cellular therapy this year, likely. We have excellent results regarding non-malignant disease with 96% of overall survival and only 4% of TRM. And for malignant disease, we are in the normal range of what we can see in the other centers in North America. Our future direction is to try to decrease transplantation-related mortality with better control of infection and graft-versus-host disease. And the main issue remains relapse for malignant disease. So our colleague, Dr. Duval, is developing currently a protocol of immunologic intervention after transplantation, after allogenic stem cell transplantation, to trigger immunologic reaction from natural killer cells against cancer cells. And we hope this treatment will open soon and will be effective. And finally, I did not present this issue, but long-term toxicity, especially related to TBI, is also a big concern for our patients. For now, it's not possible to remove TBI from the conditioning for acute lymphoblastic leukemia. We tried in randomized trial, but the result decrease of survival when we remove TBI. So maybe if the protocol of immunologic intervention work, we could in the future decrease or remove TBI from conditioning for acute lymphoblastic leukemia. And with that, I have finished my presentation, and I will let Dr. Bittencourt present.
Stop sharing. To share. Put on. Okay. Okay. So thank you. Thanks so much for the invitation. So I'll talk about our results, in fact, of the commercial CAR T that we start 5 years ago. And 5 years ago, I present here at the same. What should I do? Just close. Okay. And so I present here 5 years ago about CAR T when we were just starting, and five years later, so I have to present our own experience with that. So this is my disclosure. And so we use CAR-T for BLLL. So, and this is the results that you have in COG and in Canada for BLL. So the results are quite excellent. But we still have around 10 to 50% of patients that are refractory or relapse with the first-line treatment. And when you talk about this patient with the conventional treatment, the results are not quite so good, okay? And if the patient, for instance, relapse in the first year and a half, the survival with the classical treatment is quite low. And so the aim in the last 10, 15 years were really to try to change gears, to try different approach with immunotherapy. So I put here this cartoon, and we have roughly three approaches for that. Antibody that's conjugate with chemotherapy, CAR-T, and bispecific antibodies. And I will talk specifically about CAR-T, that is acronym for chimeric antigen receptor. That, as Dr. Teira mentioned before, is in fact is a genetic modifying of T cells that you use. And this is the CAR-T that take the best of both receptors that you have on lymphocytes. So it takes the B cell receptors and take the machinery of the T cell receptor. With that, I can recognize a peptide, a protein that is outside the tumor cells without presentation for the HLA, the measure histocompatibility complex. And this is a cartoon of how it works. So we use a lentiviral, in fact, that will transfer the code or genetic code of the CAR-T for T cell, and then will be transcribed and present in the surface. And with that, we have the specificity to recognize, in this case, the CD19 that present in the leukemia cell, and the CAR-T will eliminate these cells. This is the process that you have. So the first things you have to have T cells from the patient. So we do a leukapheresis. With the commercial one, we send this to Novartis that manufacture the T cells and transform this in CAR-T. Is a process that take around 9 days, and more than that after to the quality control, in fact. So usually it takes from vein to vein roughly 4 weeks to have the cells back to infuse to the patient. And the infusion usually is preceded by a chemotherapy that we call lymphodepletion. It's a sort of we prepare, in fact, the patient to receive a decrease, in fact, his or her immune system before the infusion. Is a transfusion that usually takes 5 to 10 minutes. This is the trial that in fact validate the indication, and this the registration trial, in fact, for the CHU cell, that is the CAR-T that we use. We have 81% of complete response. If you use intention to treat for all the patients included in the trial was 66%, and most of these patients that were treated were MRD negative after the. Okay. This is an up-to-date of the data from the trial with 5 years follow-up. So we have 44% that were in remission, that were still in remission 5 years later, okay? And an overall survival of 55%. So if you remember the curve that I showed you before, with the standard treatment, especially for the bad player, like this one that you put in the trial, it's really a huge increase in terms of survival. And so we always questioning, there is always question about, yes, this is in the trial, what is in the real world, and what you are seeing, in fact, in patients that receive this the commercial one, that the result are quite the same. You can see the complete response of all intention to treat are similar or even a little bit better, and most patients are MRD negative. So the results are reproducible in the real world. The CAR-T, it came with some toxicities, okay? So the CRS, the cytokine release syndrome, and the neurotoxicity that relate to the infusion that usually happens in the first month. In fact, the CRS in the first 2 weeks, and the neurotoxicity that can happen up to 1 month after that. It's mainly related to the burden of the disease. So patients that have less burden when infused have less complications. Okay, and a complication that is present in the long term is B-cell aplasia, because the only benign cells, normal cells that is affected with this CAR-T is B lymphocytes. Okay, so the B lymphocytes are completely eliminated with the CAR-T as long as the CAR-T is on board. Patients do relapse, okay, and there is two kind of relapse that you see after the CAR-T. We have relapse that the patients still have the target that were at origin were aiming to eliminate. So this is usually related to even lack of expansion or lack of persistence of the CAR-T, because we need usually a minimum of 6 months of persistence of CAR-T to have a better result. And rarely we have disease that unfortunately proliferate faster than the CAR-T. And the other type is CD19 negative, so it's immune escape, in fact. So it's not a problem of the CAR-T, but it's the leukemia that found a way to escape. Usually they downregulate or complete abrogate the expression of CD19 by mutation, okay? And is mainly related with the tumor burden. In fact, the more leukemia the patient have, the more the patient has chance to have mutation within the burden, and we're going to escape after that. So I'll talk about our results for the commercial CAR-T, the T-Gene cell, which is a cell, as you know. I do this very recent, so I'll be present the results until last month, okay, for our patients. So we just infused this week our 50 patients, okay, englobes the research and the commercial one. And for the commercial, I'll talk about 35 patients, in fact, that have been apheresis. So we have so far just one patient that you have to do 2 apheresis due to potential contamination, in fact, in the cells for the first one. What you have, and you are probably lucky so far, we have no problem of manufacture. That is a problem that can happen in 2 to 4%, and all our patients were infused. So we have 32 patients that will have a minimal follow-up, at least that you have the patient is in remission after the infusion. So the age of at diagnosis, the median is 4.6, I put in French, I thought is, years, and 7.8 years at infusion, okay? A little bit more boys than girls. We have just, for the commercial, just one patient with trisomy 21, and we have no patient that have received a transplant before the infusion. This is related to our strategy, in fact, to try to use CAR-T before transplant. The indication that you have, so most of our patients are what you call refractory BLLL, but the criteria is quite variable. There is patients that have cytological refractory, but you have patients that have also MRD that persist even after 2 or 3 cycles of chemotherapy. Okay, and most of our patients are patients that are refractory after a relapse. In fact, we have 5 patients that we infuse after 2 or more relapse, and 4 patients that we did CAR T, in fact, to try to prevent toxicity with the treatment. The response to the treatment, in fact, we have 97% of patients that were in complete remission. 31 patients that were available. 1 patient died before we were able to evaluate. And if you consider all patients that we apheresed and infused, were 94% of complete remission. All these patients were in MRD negative, so we have no positivity at the first evaluation. But if you use more sensible assays, just like PCR, we had 3 patients that were able to detect the disease after the infusion. In terms of toxicity, so we have the CRS in about 2/3 of the patient. Fortunately, most of the patients have a mild or moderate CRS that we didn't need treatment. The median was 4 days, in fact, and we used tocilizumab, that is the standard first-line treatment for CRS in 9 patients. Neurotoxicities, we have very few. We have just 2 patients that have, and no patient that have severe, in fact, neurotoxicity. This is our results. So this is the event-free survival for our patient, okay? And I put 3 years as a landmark. So the events are loss of CAR T, okay, relapse and death. So 3 years after the infusion, we have 38% of patients that we infused that we did nothing after that. Okay, we're just following this patient. I put CAR T loss because, as I mentioned before, this is very important. The patient that lose CAR T in the first 6 months, the relapse rate is about 80%. Okay, so we have to manage this patient if the CAR T is lost early after the infusion. This is the disease-free survival for a patient is 70%. Okay, here we include this patient that we treat and do nothing, but include also the patient that lost the CAR T, but before the relapse, and you will go to transplant with this patient. So we have 70% of patients that are free of the disease. And this is our issue that you have, and you have to do better. So in 6 months after the infusion, in fact, at 6 months, we have half of our patients that lost the CAR T. Okay, and so this is our probably the main issue that we are trying to address right now. And the overall survival for our patient in 3 years is 90%. Okay, with this kind of patient, it's quite it's very impressive to have. But for sure, in this cohort, we have a significant number of patients that have been transplanted, and that's what you have to try to decrease. As Dr. Teira mentioned before, this patient we have to transplant with TBI, with a lot of short-term and especially long-term complication, and that's what we're trying to avoid. So we have a lot of things to do. What is the perspective that you have in the future? So the first one, as I said, we have to try to improve the persistence of the CAR T, and there is maybe an intervention that is not very expensive to do. There is 2 trials in pediatrics that show that the level of the fludarabine is one of the chemo that used in the lymphodepletion before the infusion. And the two trials show the same things, that the patient that have a higher level of fludarabine before, they have less loss of CAR-T, they persist more, okay? So this is strategy that we're trying to do at this very moment. So we are just start doing the PK of fludarabine for our patients. So we are adjusting, in fact, the dose based on that. There is an issue of that, in that we have access to this, but most of the centers don't have. And we are discussing a trial, a Canadian trial with CHEO, try maybe to increase the dose for all patients. In fact, we estimate that to increase about a third of the dose, we are able to put almost all patients in the target dose. We are trying to find funding for that. And the second one is what we call let's do the CAR-T more democratic and cheaper than it is right now. And this is the strategy of point of care management. So it tried to use a little lab in a machine. So there is two kind of machines to do that right now. So we're able to do this in the cell lab of our own hospital with that. And the example of that is the CLIC-1 trial that have been developed here in Canada. Natasha Crack here for the TOH, and there's really results that are quite similar to what you have with commercial CAR. And there is an initiative that was recently found that is developed a network of pediatric CAR T cell for manufacturing. And the idea with that is to try to improve, in fact, access for the patient. So to try to increase the network, so to bring other hospitals to be able to infuse the CAR T as well. So it's Amanda Lee and Georg Kruger that are the PI for this. And there is two parts of that where finance for the first one. So there is two aims, in fact. The first aim is to prove that we are able to do the same CAR T on different labs, okay? So this is the first aim where we're going to manufacture it. We'll use the CLIC-1 and probably the CLIC-2, in fact, vector to do that. So the aim is to show that we are able from east to west to do the same cell, okay? And the second one is really to try to standardize the management of the patient and to facilitate, in fact, the access of this kind of therapy for other so training, and to see what will be the logistics that we have to put in place to develop this network. And the second part of that will be really to, in fact, manufacture and deliver CAR-T for trials. And fortunately, we're able to do this in more hospitals than just right now. We have just 6 hospitals, in fact, pediatric hospitals in Canada that do cell therapy. So we have to democratize this as well. So this is our presentation. And thank you so much. And we are open for the questions.
Thank you so much. So we have a few minutes. I invite the audience who's here to come forward and ask questions. I think that Rachel has a microphone over there. Thank you. For audience members to come up to ask questions. And then for those who are online, please feel free to put your questions in the chat. So any questions from me? Okay, thank you, Anne. Go ahead.
improvement, progress, collaboration with different minds. So this is very lucky to have this collaboration and this aspect of standards. I will say that again, from my perspective, to see a high picture inside. I have been master.
With our advancing ability to edit.
That's part of my job. I get even back and go to school and with my students. So thank you so much. I looked at with 5 patients from Newby. And so this has been added to the team because it's not just doing they're not experts, but taking care of these patients as part of very comprehensive care. This is for the rest of the team that is here as well. Like really just thank you because it was not easy for the families. I guess my question is on Tortilla and now it's great to see the evolution and not, but we had some things, so I'm going to ask you what you're seeing, like, did you hear that this is on page?
So,
And would
yeah.
you mind repeating the question because those online?
Okay.
Yeah.
So the question is about the infection. What your experience of infection with the CAR T patient due to the BCL aplasia. In fact, to put all this patient on immunoglobulin, first IV, and then we transition it to subcutaneous. We do not see also major problems with this patient, so no hospitalization. What is quite amazing is that the patient usually 1 month after 2 months after infusion, they are back to school. So they go back to the life, so normal life quite fast. On the other hand, what we're talking about this a few days ago is that it's like there is a lot of patients that have a little cold that do not go away. Okay, that's what we see with this patient. They are really a little runny nose, clear with that, and probably related to the fact that yes, we put IgG, but we don't have any secretion, so on. So it's probably related to that. We have half of the patient that lost, it's not probably in the long term, they transplant they put, but for the patient that in the long term, that there is no really issue.
Can one get, I guess.
So there is, so for sure there is the research on that. We're quite not that advanced to put this in clinical trial as long as I know, but there is really perspective, and for sure with the new tools that we have, it became possible to do that. The other thing I think in terms of the target, so we are very limited with that. We have just one target to do. What we're aiming, in fact, for the Canadian initiative, try to use 2 different targets. In fact, to try to improve, and that's a little bit the evolution of the leukemia treatment. That at the very beginning we start just with one drug that put in remission, then the leukemia start bad, and then we learned that you have to add combination. Then we were able to have better thing for CAR-T. I think will be the same. We're still learning how to use, and we are doing what you have in hands. But sooner we'll have more target to do this work.
Great, thanks very much.
Thank you.
And then we have 1 minute. Okay. Yeah.
Thanks again for a great presentation. Hopefully people online can hear. Another non-malignant question, thinking about the inherited metabolic diseases and gene-modified autologous stem cell transplant therapies. MLD is here, adrenoleukodystrophy is kind of here, is coming, several others in the pipeline. Do you anticipate any system changes that you're going to need at your end to accommodate these types of therapies into your program?
So gene therapy was and is always a big hope for patients with sickle cell disease or immune deficiency. So technically it works, definitively. Clinically it works. The issue is the access to this kind of treatment. We have several immune therapy protocol in North America for immune deficiency that are very hardly to have access to. These protocols are developed in academic centers, so there is quite nothing to pay for. And now we have commercial gene therapy that are coming for sickle cell disease with a tag price in US for now about $1.5 million a shot, without taking account the cost of hospitalization. So we have a company, the name is Vertex, who this week had the approval of Santé Canada. So Santé Canada recognized that, Health Canada recognized that the treatment works, as it was demonstrated in US. But now we are waiting for the response of the provincial agencies in charge of accepting the cost of treatment, and it will be another issue. So at Sainte Justine, we are working from a center for gene therapy, so we'll be able to govern that. So big hope, but still very, very limited access. And the other issue is, for instance, there are some diseases where gene therapy is certainly the best option, but there are also diseases such as sickle cell disease. We do not know exactly what is the best option. There is no comparative trial instead of allogeneic stem cell transplantation. So there is a lot of work to define what are the good indications and the best option for patients if it's available.
Well, another comment on that. There is an issue also with the model of commercialization that we have so far. We are right now, the model is dependent on industry, and most of these diseases are rare disease, and so the tag price is enormous. Okay, and so it's hard, in fact, for the industry to aim, in fact, to develop this, because they will have to put the price in the 5 million, 10 million, and it's not practical for the stand. So I think the other discussion is to change the model. In fact, I think we have to change the model. I think earlier what we are proposing, in fact, with this CAR-T initiative, in fact, is to try to address a part of that, okay, to develop this in academic, but it will be another issue when you have to prove that the product works, and then who will pay for that, who will register that. Probably don't have the industry from back. So I think there's a huge discussion about the model. The model, I think we think, in fact, it's interesting that we have to change the way.
There's a hand up. Okay, I'll give you the last word. But
Hello?
yes, we hear you, but there's a lot of feedback.
Okay, well, thank you very much. It was a very good presentation, except it seems that I got lost into various alphabets and acronyms. And my question here is that there are a lot of diseases you can treat with these methods in there. Numerous diseases. I'm looking at, I made some notes in here. But if you are using auto and allo, as well as your CART, have there been any instances that you changed from auto to allo or to CART in terms of failure of one type of disease?
Thank you. Thank you for the question. Yeah. If I understand, is that if you can in fact change the indication from allo to auto and CAR-T, and so it depends really on the strategy and on disease. In fact, for instance, we use for neuroblastoma that usually do autologous transplant, and you have some patients that fail to that, and you do up to identical transplant. For CAR-T, our strategy is to do the opposite, so try to use the CAR-T to decrease toxicity, and then to go to transplant if it do not work. And in fact, for sickle cell disease, for gene therapy, and for in fact for most of the current gene therapy that modify the stem cell, we do an autologous effect. For this, we collect the patient, we modify the cells and do an autologous transplant for that. I don't know if I answer your question about it.
So thank you all for joining us online and in the room. And thanks again to Dr. Teira and Dr. Bittencourt and the entire Sainte Justine team who's made their way to Ottawa from Montreal. So but again, thank you everyone for joining us.